Good afternoon, my name is Zahir Abbas. I'm a physician associate. Can I confirm your full name and date of birth, please?
Yeah, my name's Subhan Mahmood and it's the 27th of March 1999.
And how would you like to be addressed?
Subhan.
Subhan. How old are you now, Subhan?
24.
Lovely. Subhan, like I say, my name is Zahir. I've been asked to conduct an A2 examination given the presentation that is today. That will entail me having a look, listen and feel of your chest amongst a few other components to the examination. I will talk you through those as I go along. If you want me to stop any time, please don't hesitate to do so and we can do that. Is that okay with you?
Yeah.
Lovely. Now, part of the examination, what I'll also need to do is I'll need to ask you to remove your upper garment and your lower garments, but we'll do that as we progress from the examination. Before I begin, are you in any pain or discomfort?
I'm not.
Lovely. So what I'll do is I'll just don my gloves and then we'll go from there. Are you okay for me to begin? Lovely. So, A for airway, and I'm just assessed, having spoken to the patient, the airway is patent, it's maintained open airway, and there is no obvious evidence of stridor or gurgling sounds of breathing, any challenges there. So I'm quite satisfied the airway is, like I say, intact and patent. From there, I'll go into breathing, and looking at the patient's breathing pattern, it appears to be normal breathing rate within the ranges 14 to 20 of normal depth. The chest seems to be expanding bilaterally and there appears no obvious use of accessory breathing muscles. So what I'm going to do is I'm going to tap on your chest, if that's okay, sir.
Yeah.
Good. Just bring your arms onto your fifth and lean forward for me if you don't mind. Nice and upright, that's it. Lovely, thank you. I'm now going to have a feel at your chest just on the front, if that's okay. So just nice and relaxed. And give me a big deep breath in and back out. That's wonderful. If I could trouble you to sit in again. Big deep breath in and back out. And now I'm going to just have a quick listen to your chest. Stay as you are if you will. Breathe in, out. Just going to go under there. In, out. Going to go to the back. In, out. In, out. In, out. In, out. In, out. In, out. And just finish off, hands on your hips again. In, out. In, out. Lovely. Sit back if you will, please. Thank you very much. So there was good air entry bilaterally, and there was good equal chest expansion bilaterally. Percussion, there was there was no dullness of percussion or other concerns on that. I'm now going to have a feel at your pulse, if that's okay, please. No, stay as you are. That's good. So for 15 seconds, and here we have a pulse that is normal, 72 beats per minute, 76 beats per minute, normal character, good volume. I'm just going to have a look at your hands if I might. There's no obvious evidence of cyanosis. Just going to pinch at the top. Any pain?
No.
Tap refill time, press for 5 seconds, release, and it's less than 2. And again from here, I would have a look at the patient's sternum and would press down on here and press and hold for 5 seconds, assessing for central cyanosis, as well as just looking at the mouth, the nose and the perioral region. Open your tongue and lift up the tongue, mouth and lift up the tongue. Again, there's no sublingual cyanosis indicative of central cyanosis. The blood pressure here would be beneficial. We'll see from the observation chart, as will the oximetry, the oxygen saturation on room air, again, as we can pick up from the observation chart in a few moments at the end. Moving on from C, circulation, we move on to D for your disability, and here what we're going to do is essentially we're going to have a look at the patient is responding. The GCS is 15 out of 15, so your eyes, your voice and your motor all measuring 4, 5 and 6, and here we've got 15 out of 15. The patient is oriented in time and place. What we'll do is we'll also assess the BMs again from the chart or from the nursing team, see whether or not they were hypo or hyperglycemic, and then I'm going to have a look in the patient's eyes. So if I might just trouble you to look straight up to the ceiling there for me, I'm going to shine a light in your eyes, Subhan, is that okay?
Yeah.
So, okay, good. Okay, lovely. And I did a swinging light reflex there, and we've got what we refer to as pearl. Pupils are equal and reactive to light. There are no unilateral deformities or mydriasis, such as any unilateral mydriasis. I'm struggling to recall the name of any right now, but there's no obvious deformities of the upper eyelid, such as partial ptosis or otherwise either. From here, we'll go then onto the E4 exposure. At this stage, I would ask Subhan to remove his upper garment, and I'm looking for any obvious signs that are perhaps unexplained or abnormal. Typical things here might include distension of the stomach. I will assess the stomach, so I'm going to do that in a moment or two. But on observation, you're looking for the likes of Cullen sign, your Gray Turner sign, Fox's signs, all indicative of hemorrhaging, albeit in different regions. Remember, Cullen, C for central, that's your umbilical region. Your Gray Turner sign around the flanks, so retroperitoneal hemorrhage generally speaking, and the Fox's sign in the groin region, again hemorrhaging that might have occurred. Now remember, hemorrhaging could have occurred elsewhere, but due to gravity, the blood has poured in an area that's different to the site of actual damage. And of course we will also look at the lower extremities, again for any obvious deformities, looking at the calves, looking for any obvious signs of atrophic change on the lower extremities, and then pitting edema. We will assess for that, and we'll assess the calves for any tenderness that might again indicate abnormalities such as DVTs, aside from the gross obvious deformities such as that which we might find in the neck or femur fracture, for example, where the leg is externally rotated and or shortened. So, Subhan, if we just lean forward slightly for a moment, I'm going to flatten the bed. Lay flat if you will, please, sir. And I'm just going to feel at your tummy, okay? So again, as usual, as part of the examination, what you're going to do is do all 9 quadrants. You're going to do light palpation, followed by deeper palpation, and again, assessing. I'm not going to conduct that here because it's not warranted. Lift up again, if you will, please, and lean back again. But the percussion is also important. You can assess for any pulsatile masses in the context of AAA, or you can, when you do the percussion, you can be assessing for bladder distension. Remember, although the bladder is a pelvic organ, it can actually be raised up into the abdominal cavity. The pupil I was referring earlier to was the example with Holmes, Addy pupil, and Argyll Robinson pupil, and these are typical examples of unilateral mydriasis, which may be actually normal for the patient. Again, while you're there, you can look for corneal arcus, casiflacial rings, pterygium, amongst a whole host of other abnormalities that might be visible. So there you have an A2 examination on Subhan. Subhan, thank you very much for your time.
Thank you.
Do you have any questions for me, sir? If the patient hadn't dressed down and remove any garments, then of course you can ask them to dress themselves. And to finish off, I'm just going to sanitize my hands. Thank you very much.
Thank you.
You're most welcome.